this session is going to be recorded as well. So we are able to hopefully share this with a greater audience after. As a reminder, and I did put this in the chat, please make sure that you are on mute for the entirety of the presentation, just so our panelists can be highlighted, as well as the recording can have the least amount of distractions that are possible. This is an informational session and really meant to have some sharing of ideas as to how we're catering our practice and how we're targeting our practice in different institutions and across the country. This is not meant to give you a complete and thorough overview of the pharmacotherapeutic agents for COVID-19 outpatient therapy. So our panelists will really be able to speak on their experience and their involvement in the treatment guidelines. Any questions for our panelists should be entered in the chat, and I will be moderating. I will make sure to get to those as soon as able. And just to give you a brief schedule of what we are hoping to highlight in this next hour is a brief introduction to our agents. Again, if you could mute yourselves, that would be great. Thank you. And then we will talk a little bit about the allocation acquisition of these treatment options, because I know that that's very different across the states. We'll then discuss prophylaxis, so that will primarily be with tixagevimab, cilgavimab. I will, for now, rename that as Evusheld because you guys don't want me splitting over those. And then we'll go into some of the treatment with Sotrovimab, Paxlovid, and molnupiravir as well. So again, I appreciate you guys being on mute and your involvement, and we really appreciate our panelists. I'll go ahead with our intros. So my name is Krutika Mediwala Hornback. I am the chair-elect for the ACCP PRNs, and I am a infectious diseases and antimicrobial stewardship pharmacist at MUSC Health in Charleston, South Carolina. I'm primarily involved in stewardship activities. My areas of interest are DEIB initiatives, as well as some gram-negative mechanisms of resistance. Similar to our panelists, specifically to COVID-19, I've been actively engaged in some of the therapeutic guidance, education, and process development across our entire 7-hospital now enterprise. So I'm looking forward to really learning a lot from our panelists. Our first panelist is Dr. Carollos Hanna. He's a board-certified Board of Pharmacy specialist in oncology, pharmacy, and pharmacotherapy. He received his doctorate of pharmacy from Florida A&M University and completed his general residency at St. Thomas Hospital in Nashville, Tennessee, and his oncology residency at St. Luke Mountain States Tumor Institute in Boise, Idaho. He is currently an assistant professor of pharmacy at the Mayo Clinic College of Medicine and the oncology pharmacy manager at mHealth Fairview in Maple Grove. Dr. Hanna also serves as an associate editor for the Journal of the Advanced Practitioner in Oncology. His research interests are focused on B-cell malignancies and genitourinary cancers. He's published over a dozen manuscripts in various journals, and he's an active member of the Hem/Onc Pharmacy Association, Association of Community Cancer Centers, Aplastic Anemia and MDS International Foundation, and of course, the American College of Clinical Pharmacy. Next, we have Dr. Dana McManus. Dr. McManus received her Doctor of Pharmacy degree from the Ernest Moriarty School of Pharmacy at Rutgers. She completed her postgraduate residency training both years at Yale New Haven Hospital in New Haven, Connecticut. She currently serves as the Senior Clinical Pharmacy Specialist in ID at Yale New Haven, as well as the PGY2 ID Residency Program Director. She is also board certified in pharmacotherapy, as well as infectious diseases. Dana's professional areas of interest and research include stewardship and resistance in immunocompromised patients, as well as quality improvements in patient safety.
Roots are always first on the scene to
she is also has numerous publications and presentations related to ID, including areas of COVID-19, which is very appreciative. She's also an active member of ACCP, SIDP, and involved in a number of communities within these organizations. Then last but not least, we have Dr. Nick Lange. He practices at NewYork-Presbyterian Hospital or at Columbia University Irving Medical Center as a board-certified solid organ transplant pharmacist, specifically with the kidney pancreas transplant program. He received his doctorate of pharmacy from Massachusetts College of Pharmacy and Health Sciences and completed both his PGY1 and PGY2 residencies at New York-Presbyterian Hospital. His research interests include optimizing use of transplant immunosuppression, managing opportunistic infections in immunosuppressed hosts, and evaluating drug-drug interactions. He's published over a dozen peer-reviewed manuscripts in a variety of transplant and pharmacy journals. So we have some rockstar panelists for this evening. I'm really looking forward to it. I will be trying to play the mute police, but if you could also help me out, audience members, by making sure you are on mute so we can give our full undivided attention to our panelists. Great. So we'll start with a brief introduction on these agents. Dr. McManus, could you give us a little bit of a brief intro on Sotrovimab?
Sure. So Sotrovimab is one of our 3 monoclonal antibodies that we have approved through emergency use authorization for treatment of COVID-19 in patients with mild to moderate disease. It's given as a one-time IV infusion, and it has been shown to decrease chances of hospitalization.
She got muted.
Dana, just hold a second. You got muted. I apologize.
Sorry, that's okay.
All right. I was trying to do that for the audience. Go ahead.
No worries. So I'm not sure where I got muted, but it's been shown to reduce the risk of hospitalization and progression to severe disease in patients with mild to moderate COVID. And unlike the other monoclonals, which are not active against Omicron, which is our currently dominant circulating variant, it does retain activity against Omicron. So really the only one that is reliably efficacious at this point in time, given the current variant that we are dealing with in the US.
Awesome, much appreciated. Dr. Lange, can you talk a little bit about the 2 oral antivirals that we have with Paxlovid and molnupiravir?
Yeah, so both are similarly approved under emergency use authorization by the FDA for mild to moderate COVID in ambulatory patients, aiming at preventing hospitalization or death within a month. That's the kind of primary endpoint that's used pretty consistently across the literature with these novel therapeutics. They're both twice daily oral medications taken for a 5-day period. Paxlovid is a little bit tricky in that, it's co-formulated with ritonavir. And so I'm sure, as we'll talk about later in this panel, that poses a lot of challenges for us as clinical pharmacists, of course. And similar to Sotrovimab, fortunately, both of these orally available COVID therapeutics are still demonstrating efficacy against the Omicron variant. So we've still got those in our arsenal for now.
Great. Thank you. And then Dr. Carolus, Hannah, could you speak a little bit on our prophylactic agent that we have with Evusheld?
Absolutely. Thank you, Dr. Hornback. So in terms of Evusheld, this is really an injection formulation. It's a combination of 2 monoclonal antibodies, IgG monoclonal antibodies. One is called tixagevimab, and the other one is cilgavimab. And both of these do have to be given at the same time. They are not mixed. They are intragluteal injections. So oftentimes we're given these in the infusion center. Currently, the Evusheld, just because it's a much easier name to say, it currently is indicated in adult and pediatric patients also under the EUA. These pediatric patients are 12 years of age and older and have to at least weigh 40 kilograms or greater. Ultimately, how Evusheld works is that it can bind to the regions of the SARS-CoV to spike proteins and prevent them from viral attachment with healthy human cells. But based on the indication in this pediatric and adult patient population, it's really intended for moderately to severe immunocompromised patients. So those who have conditions that deem them to be immunocompromised. That could be solid organ transplantation. It could be cancer. And ultimately, it's intended as a pre-prophylaxis agent. It's not intended as treatment for COVID-19. It is not intended as a replacement for the vaccination for COVID-19, but as a pre-exposure prophylactic agent. So we give this to those patients, and it can be given in combination with the COVID vaccine. And we'll talk about some of the stipulations in terms of those that may be infected with COVID, those who are getting vaccinations, and timing and those kinds of things throughout the discussion today.
Great. Thank you so much, everyone. So I know we've talked about, we've kind of briefed on this a little bit, but can you, each of you, speak a little bit on the allocation and acquisition of each of these agents at your specific institution or state level, and how it looks like at the current moment? Dana, you can go first if you want.
Sure. So for the state of Connecticut, which is where I practice, Evusheld is only being distributed to health systems, healthcare systems within the state. And so there are a number of health systems within our state that are getting it, and on an allocation basis, typically weekly. And it's based on our census of COVID positive patients is how it's distributed to the different hospitals in our state. With Paxlovid and molnupiravir and Sotrovimab, similarly in Connecticut, it actually initially was also just sent to health systems, which is a little bit different than some of the other states. It was not given to any long-term care facilities or retail pharmacies. And then as time went on a bit, the state is starting to send some supply to some long-term care facilities and some of our urgent cares in the state. But at this time in Connecticut, it is still not available at any retail pharmacies. It is only through those areas, which is a little bit different than some of our border states. And so that's, one of our challenges is we have hospitals that are in another state and border other states. So one of our hospitals in our health system is in Rhode Island, and there from the initiation of the oral therapies, they were only distributed to a select number of retail pharmacies. So our health system, our hospital within our health system that is in the state of Rhode Island didn't get any oral therapy. They did get Sotrovimab and Evusheld, but the oral therapies only went to select retail pharmacies. So, and then New York, which borders us, was a little bit different, which I'm sure Dr. Lange is going to talk about. So we've had to kind of manage that, different states bordering us and patients being treated in our health system, but living in those states, getting it from different ways. But that is how Connecticut has mostly handled our allocation.
I could probably go next, or Dr. Lange, sorry, I saw you unmuted. Go ahead.
I was just going to piggyback off Dana because we're neighbors. Yeah, it is interesting. So the Department of Health in New York oversees distribution of the monoclonal antibody preparation. So both Sotrovimab and Evusheld get distributed to health systems on the basis of disease burden and how efficiently they use their supply once they get it. The oral therapies, very soon after the FDA granted EUA, were available through select designated retail pharmacies in New York. In New York City specifically, it was exclusively available in all 5 boroughs through a specialty pharmacy in the suburbs and upstate. Elsewhere in New York, it was available at designated CVS, Rite Aid, Walmart, etc. The Department of Health maintained a list on their website that was updated in real time. Supposedly there was like real-time inventory counts that I don't know how they maintained the accuracy of, but certainly a little bit differently than how Connecticut rolled out, specifically the oral therapies.
And we're very similar to Dr. Lange and Dr. McManus. For us, really, it's been heavily dictated by the Minnesota Department of Health. For us, I would say we've had luck with some retail pharmacies in terms of the oral COVID-19 medications, but a lot of those retail pharmacies, they've been the ones in conjunction with a healthcare system. So if a healthcare system does own their own retail pharmacies, we've been able to either leverage that support from the retail pharmacy or even the specialty pharmacies within health systems. Evusheld has certainly been also allocated just to health systems because it does have to be administered under the guidance of a physician. And actually, what we'll discuss in terms of logistics, patients have to be observed for an hour post-injection. And then to make it even a little bit more complicated, the Department of Health not only is in charge of the allocation and distribution, but they also, in terms of some of these therapeutics, they also dictate more strict indications based on the allocations allotted to the state. So it's not just, I mean, if you look at Evusheld, as I mentioned, it was really all immunocompromised patients, but the Minnesota Department of Health has made specific cancers and specific solid organ transplants as acceptable indications for Evusheld, for example. As Dr. Lange had mentioned, in terms of a real-time perpetual inventory, it's really for us, it's required across the board, and we have to do it on a every single day basis. It's monitored really from a departmental standpoint. So that, again, for some of us, it has been challenging, but it's what we're asked to do, and we try to keep up with it.
Yeah, I would say I think it's at South Carolina, it's a mix of everything that y'all had just said. It's like Sotrovimab and Evusheld. Evusheld is mostly going to healthcare like institutions. Sotrovimab is going to a little bit more like a little bit wider audience, I guess, like any physician offices or something that were already equipped to do the other mAbs are trying to get some of that. But it's interesting, Dr. Hannah, that you mentioned that the state Department of Health is being a little bit more stringent given the allocation with their own guidance, like even, you know, being more strict on the allocation of within your immunocompromised. That was something that our DHAC is also doing, but they're not actually labeling that. There is a suggestion and a guidance, but everyone knows that it's not a whole lot of stock that we have. So it's a little bit difficult to actually get through all of these patients. And then we started out with 8 Walgreens across the entire state for the oral antivirals, and then expanded to 18, and that list keeps going up. And it's, again, we just have to rely on the national website to see when those go live, and really have to call each pharmacy or the, you know, the one in town to really do that, because the stock is not accurately described. So complicated is a good word to describe that. Okay, so we've talked a little bit about prophylaxis. And Dr. Hannah kind of hinted at this. So how are you prioritizing patients for administration of Evusheld at your institution? How do you, you know, like utilize some of the pharmacoethics principles to ensure that you have enough stock, but you're also being fair and equitable in the access to this medication? Dana, do you just want to start off?
Sure, absolutely. So I think, you know, sorry, did you say Dana? Sorry.
No, go ahead. Go ahead.
So sorry. I think for us, in terms of, you know, trying to allocate certain things, it really for us, you know, in terms of the healthcare systems, where we, for example, talking a little bit about Evusheld, I think the biggest thing for us has been in terms of it's kind of first come, first serve kind of basis. When we receive any type of direction from the Department of Health, we immediately communicate that with our healthcare teams to begin screening patients. So, and we also have a work group that really will begin to call patients that are randomized within a queue that may meet indications. So we're an EPIC institution, we can pull easily from our EMRs patients with certain indications on the cancer side, for example, that meet the oncologic indications that the Minnesota Department of Health has dictated for our Evusheld patient population. And then we can randomize these patients, and we can have nurses and screeners begin to call these patients to see if they would be interested in some of the select therapeutics. I'd be interested to hear from my colleagues what they're doing as well.
So our experience is pretty similar to what you described. We have a multidisciplinary group that's specifically COVID immunosuppressed focused. So representations from our bone marrow transplant, solid organ transplant, even neurology, pulmonology, because often B cell depleting therapy is given in some of those patient populations. So all of those different disciplines are represented. And the first thing that we did, because our Department of Health similarly to what it sounds like South Carolina did, suggested more restrictive criteria, but didn't actually give us anything concrete. So we developed our own criteria with that group to determine who we felt was at the highest risk and had the highest level of immunosuppression. And after we defined that list, we utilized EPIC to create lists to identify these patients also based on their diseases and also therapies that they received that would put them at high risk. And then we used that to give that to our different clinics where these patients were seen and proactively started reaching out to our highest risk patients. We kind of came up with tiered criteria. So as supply gets better, we would kind of move to the next tier, which would expand our criteria. So we tried to define the different criteria up front in these different tiers. We did this with the MAB treatments initially when they came out as well. And as supply changes, we kind of move from one tier to another to expand criteria.
Yeah, in New York-Presbyterian, we're doing something very similar. We are very fortunate to work with a very large group of very, very intelligent, talented ID PharmDs who are spearheading this. So Christine Kubin's sending out kind of weekly emails, giving us updates about if and when the multidisciplinary group that oversees our kind of criteria stratification changing. And similarly, we're using EPIC to pull med administration to see patients who've gotten medications that may put them at higher risk for severe disease, querying the medical record for patient lists. We're actually recently, I wouldn't say bottlenecked in our infusion suite, but as a means to try to kind of get this drug into patients more effectively and quickly, into patients that we think would need it, are giving it to admitted patients now as well, so as to not just give it in our outpatient infusion suites.
It's very interesting that the inpatient administration is also happening for you. Dana, I think ours is similar, that we did provide tiers on top of like where the agents are, and I was just pulling it up. So like we, for example, our tier 1 is B cell depleting therapy, T cell depleting therapy, HCT within 1 year of transplant, 6 months of a solid organ transplant, lung transplant recipients within those 6 months, any CAR T pre or post. And then I think, you know, just the process that we've been kind of following is we are using all of our infusion suites. So it helps to make it more accessible to these patients, but we're using our immunocompromised specialty physicians to put in the referral, and then one physician is in charge of kind of, you know, querying the group like, hey, is this appropriate for this patient, and then calling the patient to kind of do that. So it is a lot more steps, but I think as everyone kind of gets used to the criteria, hopefully we can get more and more therapies administered as soon as possible. Which leads me to the other question. So I know you guys talked about how the tier program and how who all you kind of engaged in that discussion, and most of your institutions have a working group. Are you able to have enough areas where these patients can go? Because you probably, you know, this is a totally separate location that needs to happen versus any of the other medications that we're going to discuss today. These patients are very high risk. So is there specific locations that you're able to identify and utilize for these patients to go get these therapies?
So for us, similar to what Dr. Lange said, we did identify some inpatients, and there is opportunity that we've been using there because we similarly are struggling with space. And we struggled with this with the MABs for treatment as well. This is a little bit easier because these patients aren't COVID positive. So that opens up your opportunity a little bit more of where you can give it. But it's still tough because some of these patients aren't seen very frequently in some of these specialty clinics. And the clinics already are so booked with appointments. It's hard to fit in additional appointments, give the injection, have the 1 hour monitoring. So we are trying to evaluate opportunities to do evening clinics or weekend clinics to try to expand some availability. We don't have that in place currently, but that's something we're looking at. And that's something we've done with the MABs for treatment. And then a lot of the specialty clinics were just similar to what you described, just trying to optimize them. So, our solid organ transplant patients, our oncology patients, they're typically seen pretty frequently in their clinics, and they have a little bit more time that can be added on to their visits. And so those patients were just trying to maximize where they're already seen and using that time. But there's so many patients in so many different areas. We definitely recognize that we kind of need something outside of just those clinic times to really be able to administer this to everyone that qualifies for it.
And we actually got a little bit, tricky, I guess, or creative with in terms of Evusheld. So when you actually look at the clinical data in terms of infusion or injection reactions post administration, it was one patient out of 3,000 plus patients. And I think on the oncology side of things, we're very used to infusion reactions or taxanes or monoclonal antibodies across the board. So we weren't really too scared of an Evusheld reaction and the recommendations coming out of this EUA. So we actually, after administration, we give Evusheld at any point in time, whether it's during a clinic visit, whether the patient is sitting in our infusion chair, but we don't occupy chair time solely for Evusheld because chair time is extremely valuable and we're all at capacity and extremely busy. So as Dr. McManus had said, these are not exposed patients or infected patients. So we can certainly get very creative. So we can actually, we have like wristbands that we can identify these patients to know who, is there for a certain drug. And again, it's only internal information. But these patients, we can have them sitting out in our lobbies. We have certain waiting areas that patients can sit in. So we'll just monitor them right there after the injection for about 10 minutes. And then the remaining 50 minutes, we generally ask them to sit out in the lobby to, again, be able to not take away from those infusion appointments that we already have.
Those are really good points. I really appreciate the inpatient possibility of them like getting that, because I think that's something that I would love to talk to my institution about, because I think we were having the opposite problem like you all talked about, is chair time is important, and some of the, based on what immunocompromised population it is, they were probably also getting seen. I think our problem here was that they were getting scheduled for their Evusheld infusion 14 days from today, for example, because that's when their next appointment is. And if you looked at our admissions, inpatient admissions secondary to like new COVID, it's a lot of our immunocompromised population. So we just had to have that discussion with the scheduling and just like with the working group, that understanding that chair time is important and the next appointment is probably easier to schedule to do that. But in those 14 days, this patient could very well end up in the hospital and have probably not the greatest outcome with those. So could we like work to kind of make this more in like urgent prioritization for these patients? Awesome. Did you have any, like, what is your major roadblock that you have identified in the dispensing of this medication?
I can start because I actually received an update today. So one challenge that we had with Evusheld, outside of the indications dictated by the Minnesota Department of Health, was, outside of the EUA, which stated if a patient receives a COVID vaccine, you have to wait 2 weeks prior to administering Evusheld because it could take away from, mounting some type of immune response, although they're already immunocompromised. But it doesn't really make sense on the opposite way. You can give Evusheld and then you can give COVID vaccine the next day. So the concept there doesn't really make too much sense. But one challenge was, if I do have an exposed patient, what's the window where I can then give Evusheld after that exposure, and determining, that it's appropriate, because it's a pre-exposure prophylactic medication based on the EUA. Another thing was, if my patient was truly infected with COVID-19, are they candidates for Evusheld? And at what point in time are they candidates for Evusheld? So because there was no direction, our system actually came out with direction today based on patients receiving a vaccine. It's still 14 days after vaccination per the EUA, because that's the only thing. If patients were truly infected, but they were treated with a monoclonal antibody, we give them 60 days. If they were truly infected, didn't receive any monoclonal antibodies for treatment, such as like the orals that we're talking about, we give them 20 days. And then for those patients who were exposed, as long as they don't test positive or are completely asymptomatic, we give them 10 days from exposure. Again, this is just our own internal recommendations. But those were kind of some barriers that we had. And then another question, and obviously these things are constantly changing. Evusheld works for roughly 6 months, right? So in 6 months from now, are we going to need another dose, or what's going to happen at that point in time? And these are things that we faced throughout the entire pandemic with everything that's come through.
Yeah.
I'd say one challenge that we experienced, I was talking with a handful of my solid organ transplant pharmacy colleagues at New-York-Presbyterian, and it was kind of slow uptake, I want to say, from our patient populations in terms of their appetite to consider these therapies, even in the setting in which their providers are kind of recommending it. I think a lot of people are really concerned about the kind of experimental nature of it. And, when you read through the fact sheet and, it's mentioning cardiac events, it's 2 intragluteal administrations. I think a lot of people just kind of immediately get turned off. And so I think we just kind of had to work on our messaging a little bit in terms of how we talk to people about it.
Yeah, we had all the same similar struggles that you guys have identified as well, for sure. And have had to do a lot of clarification that you have said as well. And some of ours is in line, some of ours is slightly different, but similarly having to answer a lot of questions. And now with the 4th dose vaccine recommendation in immunocompromised patients, that's also something that's come up. Do you get that and delay Evusheld? And so that's been something we've been discussing as well. So a lot of clarification on these different scenarios that are very commonly presenting themselves.
Yeah, definitely. So I've got a couple of questions in the chat. I think you guys have mostly handled that, answered that. Just to repeat, I think from what Dr. Hannah was saying, that for their specific institution, if they have tested positive, received a MAB, they're recommending waiting 60 days to get their Evusheld infusion. If they have tested positive and received any treatment, you said 20 days, Dr. Hannah?
Exactly, and I'll actually read it out loud to you right now. So receiving a vaccine, it's 14 days per the EUA, and I actually misspoke on one of them. If they if they are truly positive and no MAB has been received, it's 20 days, post symptoms or post positive test, whichever one is earlier. If they did test positive and received from 10 days to define that post-exposure.
Yeah, ours is 90 days with the Sotrovimab also. So that was the one where we had a difference, but we actually are the same.
Yeah. Awesome. And then there's a question about, are you waiting any amount of time after a solid organ transplant or BMT to give Evusheld? I think we talked about that a little bit as well. I think at least my institution is doing 6 months post as well, just because they will probably be on a lot of immunosuppression right after.
I think for us, post-BMT, it's very similar to what you had mentioned in South Carolina, where we did allo, it's within the first year, auto 6 months. But I think we do start revaccinating patients at day 100. So that's the window where we do want to vaccinate patients 6 months or a year, but we start revaccinating at day 100 because at that point, those stem cells have kind of begun to regenerate and they're in the bone marrow and everything like that.
Sure. Yeah. Okay, great. And then a last question of for Evusheld at least is, I know there's been talk and discussion about a 4th dose recommendation in immunocompromised patients. How do we think this is going to play a part in like our timing of Evusheld, our timing to wait, or whatever in our population?
Yeah, so it's a challenge. I mean, for us, for most patients, we are recommending the 4th vaccine if they're due for it soon, and then considering Evusheld after that. if they're not due for quite some time for the fourth dose, then we're recommending the Evusheld before the fourth dose of vaccine. So that's how we've decided to handle it. The NIH guidance is to prioritize vaccination before utilizing these agents, although when they wrote that, the fourth dose vaccine wasn't, I think, part of the consideration. But so that's why we've kind of taken that stance, and we'll prioritize the vaccination. But if they're not going to be due for over a month, then we'll do the Evusheld first, just because it's too long of a period of time. So that's how we've decided to handle that.
Yeah, we're generally preferentially pushing for vaccination as well. It's to an extent, I suppose, kind of, our hand is forced. You only have so much Evusheld, so we can't give it to everybody necessarily that we think, would benefit from it. Within our criteria, it gets allocated to each individual transplant program, to the oncology programs, to the immunology groups, et cetera. So we only have so many doses that we can give. So preferentially, we're going to do fourth doses. In some patients, as Dr. Hanna was mentioning, we can't vaccinate these people immediately status post T-cell depletion. They're not going to mount an antibody response. So those are the patients who, while they happen to still be in the hospital, if we've got, an available dose for them on post-op day 5, before they leave, maybe that's the perfect Evusheld candidate.
Great. Awesome. Thank you so much. For the sake of time, we'll definitely move into treatment, because that's definitely a little bit more of a heavy subject as well. So talking a little bit about prioritizing the various outpatient therapies, how are you prioritizing, patients who receive Sotrovimab, patients who receive Paxlovid or molnupiravir, and even, I know this wasn't in our brief discussion of the agents, but outpatient remdesivir has also entered the algorithm. So how are you kind of prioritizing which patient gets what at your institution?
I can take that first, at least. So I think generally, kind of across the various provider groups, there's a general preference for Sotrovimab to avoid the headaches associated with Paxlovid, and the general perception that molnupiravir is maybe not worth it from an efficacy standpoint. We've been pretty effective at getting our patients scheduled for Sotrovimab, either in one of our own infusion suites or referring kind of to like a partner institution. So fortunately, recently that hasn't been a barrier to getting patients Sotrovimab in situations where we're unable to. We certainly do prefer going the Paxlovid route to the molnupiravir route. Our molnupiravir experience is very limited, and only in situations, I think, where there's some perceived insurmountable drug-drug interaction or Paxlovid inavailability, at the pharmacy when they go to pick it up. So that's kind of generally how we're approaching this in like the mildly symptomatic immunosuppressed patient who's at home and calls the center that they're newly COVID positive.
Yeah, we're handling it pretty similarly. We kind of have guidance based on, some drug interactions, things like that. We also, our guidance kind of stems off based on time since symptom onset, since the orals are the 5-day window, although all of them you'd like to give sooner rather than later, but the orals have a little bit tighter of a window. So if they're in that window, then typically Paxlovid is the preferred option. If they're outside that window, then that's kind of where we go to Sotrovimab. But a lot of our immunosuppressed patients can't get Paxlovid because of, the drug interactions and other issues. So that's where we have molnupiravir as an option and Sotrovimab essentially. Most of our immunocompromised patients, though, we are kind of tend to get Sotrovimab because of some of the things that you've highlighted, Dr. Lange, with the questions of efficacy around molnupiravir.
And we're exactly the same. I mean, one of the biggest challenges with Paxlovid for us has been those drug-drug interactions. You look at oncology patients specifically, and across the board in oncology care these past 2 years, there has been a significant shift in oral oncology use in cancer patients. And a lot of those are tyrosine kinase inhibitors that would be impacted by Paxlovid. So for us, that's why Sotrovimab has really been a preferred option in those patients that are infected, et cetera. Whereas we, obviously Evusheld is a different intent.
Yeah, I would definitely. We also have a tiered approach. We're only kind of prioritizing Sotrovimab and Paxlovid just because of the limited stock in like our tier 1 and 2 patients. We have kind of provided guidance on immunocompromised patients, especially those who are unvaccinated, and then kind of go down that route, or vaccinated and not expected to kind of come up with a mount of response. Another population that we did add as our top tier for especially Sotrovimab is our pregnant patients. Just their thought process there was, you are trying to save 2 lives instead of 1, and they're also immunocompromised in that sense. So I think that is one population that our state has established that we're putting as priority for Sotrovimab, say, versus Paxlovid, et cetera.
Same. We have shared decision making for Paxlovid, but we kind of push the Sotrovimab a bit more, and there's, I think, more data and comfort with that in pregnant patients now as well.
Yeah, I think someone hinted at this, and Dr. Hanna, you talked a little bit about the drug-drug interactions. Dr. Lange, can you talk about drug-drug interactions with Paxlovid in your population? Because I have some colleagues that are very upset about some of these Takhar levels.
Well, we kind of expected that our physician colleagues were going to come knocking, asking what to do, and there would be patients for whom we couldn't get them into an infusion suite for Sotrovimab, and we didn't want to give them molnupiravir because generally it doesn't appear to be a super efficacious drug, and it's potentially got this mutagenesis, teratogenicity issue. We're already kind of concerned about development of post-transplant malignancy. So there's going to be a cohort of patients who our hand is forced in, right? So the solid organ transplant pharmacy group reviewed as much literature as we could that looked at the influence of ritonavir on transplant immunosuppressants. We put forth some institutional guidelines based on the best available evidence that we have. There's never been a therapeutic before where you're giving ritonavir for 5 days and then stop. So we put forth some recommendations. We've got a manuscript under peer review right now that's looking at some of the results of our institutional guideline. They're pretty encouraging. Our providers are comfortable on the basis of these kind of preliminary interim results, continuing to use it as we've recommended. And I'm happy to share some of that top line kind of abstract data if people are interested.
Yeah, we really appreciate that. If you want to put that in the chat or is able to, if not, we can definitely share it.
I can read 2 sentences right here. I think this will be probably the most of what people are interested in. So we had 26 solid organ transplant recipients, 20 of whom were on tacrolimus and had pre and post Paxlovid evaluable levels. All patients were instructed to follow our standardized protocol, hold tacrolimus or their mTOR for 5 days, reduce your cyclo to 20% of your baseline dose. So the median time from pre-Paxlovid CNI level was 34 days. So these patients were seen and had labs about a month prior, got 5 days of Paxlovid. Their median level was 7.7, and at a median of 2 days after completing Paxlovid, their level was 5.3, holding it. We kind of figured that, their level might be a little bit high to begin with because they're infected with COVID, and that when we throw the brakes on the metabolism, if their level was maybe in the 8 to 10 range at baseline, that it would probably only trickle down just a little bit, and it seems like that's exactly what happened. So this is kind of still how we're navigating this, specifically with the immunosuppressants.
Great. Yeah, that's very helpful. With that. Talking a little bit about the more so the Sotrovimab and remdesivir, for those institutions that may need to partner with some of the bigger academic institutions or just kind of come together and find patients that may not have access. Do you guys have any advice or experience with having to kind of collaborate with infusion companies or other institutions to make sure their patients are getting equitable access as well?
I mean, one thing that we did, because we recognized that there were a lot of community providers too that see these patients, a lot of PCPs that are not part of our health system or part of any health system in our state. So from the beginning of our monoclonal antibody process, for better or for worse, we created a paper referral form and allowed offices to actually fax us patient referrals. When we first started with the orals, we didn't allow that initially just because of supply and the complexity of it. So we are starting to roll that out now with the orals, but we've always offered that with the MABs. And we have had many of our health systems in our state run out of supply, and we've still had supply. And so they've been able to use that paper form as well to refer their patients to us. We also tried through the EDs to kind of do some patient outreach to certain patient populations that maybe don't have PCPs, and trying to have the EDs refer patients or treat patients to try to capture those populations as well. So that's some of the things we did to try to close some of those gaps. We also would take a lot of patients from long-term care early on when they didn't have access to the drugs. We would set up transport to have them come to our infusion centers to give it. We really wanted to investigate home therapy, but unfortunately our state doesn't allow us to do that with these agents since they're not FDA approved. So that wasn't something that we were able to do. We're assessing that now with remdesivir since that is now FDA approved for outpatient treatment, but we weren't able to do that with any of our other therapies. So I'd be curious to hear if others were doing that, because I know in some states that was a way that these therapies were being given.
We have a very large home infusion service within our institution, and we have gotten lucky with some of the monoclonal antibodies that can be administered in the home. Just Evusheld, not yet, just because of this 1 hour. But again, we weren't too concerned about it, so we did keep that in the infusion center. But some of the other MABs we have been, remdesivir being one of them. Now, in terms, of what Dr. McManus was mentioning in terms of referrals, I think one additional thing that I would add is we actually we built an electronic referral method through our, standard websites. So where those that live in the community, because again, majority of my state is actually rural. So, outside of the pockets where you have the large academic medical centers, because we're one of 2 large academic medical centers here that really hold the largest quantities and allocations of COVID-19 MABs and orals and et cetera. So yeah, that electronics process has really helped, and then it gets vetted more quickly through certain work groups and things like that. But we also have the paper as well when needed.
I think something that we are struggling with at on our state level was, I'd mentioned the oral antivirals are mostly in the retail setting. And so like making sure that the drug-drug interaction check and the patient counseling check and the caregiver or the care sheets and info sheets are being provided at the time of order writing by the providers. I think that's something that we are struggling with. I mean, I'm sure there's no way for me to actually know if it's happening and if all of that is happening, and you just, hope for the best. And you hopeful that the poor Walgreens pharmacist is not having to do all of that, because they're not going to have access to their records, right? So I think that's something that's a great concern on both sides, I would say, the inpatient and ambulatory settings with that. So I think that's something that we're definitely trying to work towards. And also the process of having e-scribing to said Walgreens, and one Walgreens that was probably servicing the entire greater Charleston area, for example. What if they're out of meds by the time this patient gets there? So they're exploring, we're trying to explore a home delivery option for these patients, because the last thing you want is these patients walking into a pharmacy when they're COVID positive and trying to having to do all of that with that. So I think some of those really nuanced compliance-based issues are what we're trying to figure out currently.
Yeah, we're, I guess, fortunate in a way that right now the local pharmacies don't have it. So it is all going through us. And we do have a regular retail pharmacy and a specialty pharmacy within our health system. And so they actually, for 90% of their prescriptions, they do courier service delivered right to the patient's home. So actually this worked out well for us because we already had a process in place, and basically we just piggybacked off that. And so none of our orals or our patients are allowed to come pick up. They're all delivered directly to the patient's home, which is nice because of obviously the COVID issue. You know, they don't have to leave, any potential exposures, things like that. So we were able to do that because pretty nicely we already had an existing system to support that.
I couldn't ever fathom how this worked, but the specialty pharmacy that was the designated pharmacy in New York City for all 5 boroughs similarly did a same-day home delivery service. I still can't imagine how that worked and how many people they had to hire and what that looked like, but pretty incredible and illustrative how creative people are getting to find solutions to these problems.
I offered to, you know, after work, be a delivery driver to at least like ensure some of these people get their meds. Okay, so I'll probably, given it's, we have a few more minutes, end with a couple of questions. They're kind of polar opposites. So while we're talking about treatment, you know, is there a thought that we need to identify, or we could identify a patient that maybe gets nothing in this, you know, Omicron, whatever variant comes next era? Or are we thinking all patients, especially all immunocompromised patients who are newly COVID positive, are going to need something or the other therapeutic wise?
I think it's a hard question. I mean, I think that the data definitely shows that if you are vaccinated and don't have other comorbidities, risk factors, that you probably don't need anything. You do really well. Vaccination works. I think that in the immunosuppressed population, it's difficult because they don't always respond to vaccination, you know, which is why we're trying to give them therapies like Evusheld to help have them have a response. So in that population, because we don't know if they're truly protected by their vaccine, I think they always probably are the population that I would think about always giving therapy, because it's very hard to know how protected they are. And then I think, you know, folks that are unvaccinated with any of the many high risk factors that have been identified, you know, even weight, hypertension, et cetera, you know, are some of the highest risk people as well that I think would always need therapy. But I think those that are vaccinated with, you know, more lower risk factors, I think it's kind of debatable whether you really need any therapy or not.
And you know, I think speaking to the oncology patient population, it's a very unique subset of patients, because even there has been data amidst this pandemic in terms of patients with various types of malignancies and what kind of immune response they mount to vaccine. That's ultimately what led, you know, some of the data in terms of the initial 3-dose series and then having a booster, et cetera. But for example, you look at patients with B-cell malignancies who are receiving any type of B-cell targeted therapy, your rituximab, your Bruton's tyrosine kinase inhibitors, these patients almost mount zero response to vaccines. And I think those are the patients that do have to get something like Evusheld and whatnot if they are infected. Whereas somebody who has breast cancer or prostate cancer, absolutely, vaccine is going to take care of it and they're going to do just fine. So that's really where it just becomes a little bit challenging. So those, you know, with certain malignancies, on lymphodepleting therapy, acute leukemias, those are going to be the patients I'm more concerned about on the oncology side of things.
And I think in the world of transplant, it's a bit more nuanced as well. And of course, like kind of an unanswerable question, but if I had to think about patients who could reasonably maybe be treated with nothing, it's probably the liver transplant recipient from 12 years ago who's on 5 milligrams of prednisone, got their 4th dose of vaccine, and is like at home afebrile with a sniffle. Like that patient, like maybe you could argue could just kind of wait it out and see and call us if anything changes. But I think for the vast majority of transplant patients who are on, multi-agent immunosuppressive therapies, in and out of healthcare institutions, I think those patients probably should be treated with something, with like very few exceptions.
Yeah, thank you so much for that. And then the last one I will finish with is, and this is something that someone asked in the chat, and it's really very valuable. Are you including race and ethnicity as part of health disparities for patients that will have, worse COVID outcomes? Because we have enough data that mentions that these patients probably will have worse outcomes due to their race, ethnicity, as well as the health disparities. So are you using or have you identified a way to prioritize these patients in some fashion or the other in your tier system?
Not that I'm familiar with. I think that's an important initiative and something that we should probably look into more, though.
Yeah, we have talked about this with our multidisciplinary teams and our ethics teams as well, and have tried to figure out the best way to operationalize that, and have been a bit challenged in kind of how to do that. But it has been something that we have been talking about and trying to figure out the best way to address that, because it is obviously very important based on the data that we have.
Yeah, so similar to my colleagues, we haven't really found a great way. It's come up, and I think we decided that sex and race are just going to be completely taken out of the equation. And patients currently, I guess the Department of Health kind of helps us in terms of identifying select diagnoses that would be applicable to certain therapeutics. So then we're able to just randomize, utilizing whatever resources we have, and just kind of going down a list that's completely randomized to take any type of bias or those kinds of things out of it. Because look how much things have changed over the past 2 years. Look how things continue to change, and look how much unknown there is, and how many different processes the 4 of us do just within our respective health systems. So I think even adding that additional component on top just even makes it more complicated in an extremely complicated and fragmented world that we live in.
Awesome. We have a couple of minutes. Any last words that you guys want to share? I really appreciate everyone's time.
I was starting to respond to the question in the chat, so I'll just respond verbally about the antibodies. So we have been looking at antibodies on our patients. It is hard because there's no defined, value that leads to protection with vaccination at this point. We have been looking at, whether or not they have any response. So it's helpful if it's, negative, because we know they haven't responded at all.
Right.
And then one of the things that we have looked at is the cutoff that the FDA has used for high titer convalescent plasma, although it's not the same as vaccination, but considered looking at that as somewhat of a surrogate. So that has been something that we have been evaluating and looking at. It has been surprising. Some patients that we thought would have no antibodies actually do have some pretty high antibody levels. So it's actually been a pretty interesting experience checking levels in some of these people. But, unfortunately, we're challenged with what is the right number that you're looking for with vaccination. So until we have that, it's a little bit challenging with that.
We were for a period similarly checking antibodies for vaccine response to help inform Evusheld candidacy. That eventually just got to the point where we were making rate the evil of good, and you just eventually have to draw the line and say these patients are good, and it's better given to some people than trying to make a perfect list and give it to nobody. But similarly, it's been interesting seeing who does and doesn't mount these antibody responses. It's not always who you'd expect.
Yeah, I was very surprised by some people. Dr. Lange, are you guys, were you using a certain value when you were looking at that, or just response or no response at all? Okay.
Yeah, we also are not checking it regularly. I think in our algorithm, like our CLL patients, we've talked about with negative COVID immunity, but I know there was discussion amongst our work group as well about a specific number that may or may not indicate one way or the other, but I don't think there has been any consensus on that. And the other thing for us as well is that may potentially delay identification of patients and bringing them in, waiting on to get that IgG. So I think that was also a hesitation as well, that to not cause further delay. Awesome. Well, thank you so much, Dr. Lange, Dr. Hannah, and Dr. McManus for taking the time this evening to join us, as well as talk a little bit about your experiences and your involvement in these therapeutic options for our patients. I hope this webinar was helpful. We will send out a recording after this, and thanks to all who were able to join us this evening. Have a great day.
Thank
Thanks,
you.
everyone.
Have a great night.
Thanks.
Everyone.